All right. Welcome all to this session, and I hope the previous sessions have been informative and interesting for you as they have been for me. My name is Dr. Lisi Kanya, and I am Assistant Professorial Research Fellow in the LSE's Department of Health Policy, and I'll be moderating this session. Following with the summit's theme, we continue to explore how the challenges posed by the COVID-19 pandemic can be overcome. It's just over 2 years now since the World Health Organization characterized COVID-19 as a pandemic. And since then, more than 6 million lives have been lost globally, with over 472 million cases approximately. The related deaths recorded in Africa during this period are more than 250,000, with over 11.3 million reported infections. So our session today explores the issues of improving COVID-19 vaccine rates in Africa, and our speakers will help us unpack core issues related to vaccine inequity, vaccine manufacturing in Africa, and vaccine hesitancy, among others. But before I introduce them, we would like to invite the audience to participate in this poll. So please take a minute to respond, and we will share the results later. So the question is, what percentage of Africans are fully vaccinated against COVID? Yeah, I hope we have a few answers coming in. And thank you very much for completing this poll. So I am very pleased to welcome our speakers to this year's LSE Summit. And first we have Dr. Morena Mahuana, who is the Chief Executive Officer of BioVac. This is a biopharmaceutical company based in Cape Town, South Africa. BioVac was established to revive vaccine manufacturing capability in South Africa. And its vision and mission is to establish sustainable, world-class international African vaccine manufacturing capability by contributing to protecting life through the development, manufacture, and supply of much-needed vaccines. Dr. Morena's mandate is to realize this objective of building vaccine manufacturing capacity in Southern Africa. During his tenure, BioVac has already secured 2 successful technology transfers with global pharmaceutical companies such as Sanofi and Pfizer. And this has allowed it to grow its staff complement from 24 to over 320. Morena is a medical graduate from the University of Cape Town and serves as the chairperson of the South African College of Applied Science. Welcome, Dr. Morena, to this session. And then we have Dr. Ndembi, who is the Chief Science Advisor to the Africa CDC Director. He leads the Africa CDC's partnerships for African vaccine manufacturing and vaccine strategy in Africa. Dr. Ndembi focuses on molecular virology to implement genomics capacity. His research interests include vaccine research, especially understanding protective immune responses, and genomic epidemiology with a focus on HIV diversity and resistance to antiretroviral therapy. Dr. Ndembi is a graduate of Kanazawa University School of Medicine, Department of Viral Infection and International Public Health in Japan, and is also a research professor in the same institution. He is a principal investigator on numerous grants, including the US National Health Institute, and has authored hundreds of publications in peer-reviewed and high-impact factor journals. And he's also the editor-in-chief of the Journal of Public Health in Africa, AIDS Research and Therapy, and serves on various WHO and US CDC advisory groups. Welcome to today's session, Dr. Ndembi. And finally, we have Professor Petro, who is currently the Managing Director of Afrigen Biologics, based in Cape Town, South Africa. Afrigen hosts the Global mRNA Technology Vaccine Hub under the COVAX initiative. Professor Petro has played a key part in the design and implementation of South Africa's biotechnology strategy. She has a successful track record in the strategic and operational management of technology-intensive organizations. Petro holds a part-time position also as a professor in the Faculty of Health Science at the Northwest University. She previously held the position of managing director at Pelchem, which is a global manufacturer and supplier of commodity and specialty chemicals. A considerable part of her career was in research and development at the South African Medical Research Council, as well as the Council for Scientific and Industrial Research. Professor Petro has many qualifications, and I'll just say some of this as relates to today's session. She has a Master of Science in Medical Oncology and Cancer Biology, and that's cum laude, well done, from the University of Pretoria. A doctorate in Oncology and Cancer Biology, also from the University of Pretoria. And postdoctoral, she was a visiting scientist at Harvard University, completing a management course at MIT. And she's authored more than 200 papers. And she was recently acknowledged as one of the legends of science by the Academy of Sciences of Africa. Welcome, Professor Petro, and we look forward to hearing from all of you. As usual, we will have a chance to put the audience, you will have a chance to put your questions to our speakers. Please use the Q&A feature, and the panelists will respond to your questions at the end. So I would like to kick off the discussion by asking you to reflect on your greatest learning over these last 2 years. And this is to our panelists. What surprises you most? 2 years since the onset of the pandemic, or what is the greatest lesson for you? And I'll start with Dr. Dembi. What have we learned?
I think I'm going to start with this. This is what we have learned. Mm-hmm. I'm very serious about it.
Yeah.
Because the pandemic is not over. Mm-hmm. And it's very important. Mm-hmm. I'll take it off later on. Mm-hmm. I think we've learned quite a lot. I think, one, we're dealing with a virus that we don't have controls of. Very important. A lot of unknowns, and you're quite aware there's actually change in terms of implementation of our COVID-19 response across the globe. One, you're quite also aware that in the West, they have scrapped more of the preventive and social measures. And what we're learning now is upsurge of cases. For example, UK recorded more than 3 million cases in the past coming weeks. So I think we are dealing with a very challenging situation. I think it's unique in our whole life, except if you're more than a century here. We were born before or during the 1918 flu pandemic. But the point here is that we're dealing with a lot of unknown. No, it's not unpredictable where we're going to be in the next 3 months or what's going to happen. That's number one, as I've said. Number two is in terms of lesson learned from Africa in terms of health security. It's important. So we've learned our lessons. We need to build a resilient health system. I think that's number two. And number three, for me, from our own perspective, I think it's really an historical moment where we have Africans, like we have now Morena, we have Peter on this call, that have really built or working closely to be sure that we have vaccines for this continent of 1.3 billion people. I'll pause there on that reflection, and over to you.
Thank you. Dr. Morena?
Yes, thanks, Lucy, and thanks for the LSE to invite us to this forum. Mm-hmm. I think, one of the lessons, and this is really whether you talk about the area that we're in, vaccines or any other, I think one of the things that we've learned over the past 2 years is that over the past 3 decades, there's been a whole concept of globalization, where we have manufacturing hubs. A product can go from one part of the world to another in 24 hours, and that was live pre-COVID. And with that, it told us on many commodities, and we'll obviously talk about the most precious commodity now being vaccines, but on many commodities, it really showed that whilst those concepts of globalization were noble, but human beings typically act very selfishly when it's a time of crisis. And so the globalization concept essentially disappeared. Everybody looked after themselves. And so we got into supply chain crisis of just about everything, from health products, which is important, like masks, which are now a very basic commodity. But I mean, there was a shortage of masks. I mean, not even talking about deep things like vaccines, but just, PPEs were a big issue at the start of the pandemic. Now, who would have thought that, such commodities would have been a challenge? So I think it has certainly shaken up a bit of the globalization concept that we got used to about, and we probably that was what we started only knowing, that no, I don't need to do something, I can get something from wherever and can come in 24 hours time. But I think the pandemic has really shown us that, in desperate times, people look after themselves, and unfortunately the least, the people that have the least will always get to suffer. And again, I think the story of vaccines is probably obvious, but you can just extrapolate what I've just said about that. But let me pause there, Lucy, and I'm sure we can expand on this topic.
Yeah, exactly. Thank you. Thank you for your reflections. Professor Petro?
Lucy, thank you. And LSE, thank you very much for the opportunity to participate and to share the stage with my two colleagues. Fully aligned with what they've shared. I maybe want to add something that for me was in the early days, and as the pandemic developed, a surprise, and it may have consequences. And the surprise was that we were all so fearful on the continent all at the same time. The global community was scared. And as the pandemic unfolded, of course, inequalities became so imminent and so clear. But what was surprising for Africa, if you look at the statistics in 2021, when there were 2 million cases of COVID-19 confirmed in Africa, and with a much lower death toll pro rata from the rest of the world, there were 36 million cases in the Americas and 38 million cases in Europe. And the case and his team has done work on that for us to understand that. And part of the reasons is if you look at the population demographics of Africa, 94% of our population are below the age of 60, and our median age is 20. So we're a young continent. The other important factor is that we are very rural communities. Up to 60% of our people live in rural areas. And the problem that, not the problem, but the issue that is that we may have a delayed pandemic, because we know on this continent all 4 of the variants of concern are present. We have documented cases of all 4 of these. And we will have to be very vigilant and careful on how this pandemic unfolds further for this continent, in a vaccination rate of about 14 or 15%. The other steep learning for us, or surprise for us, was how the world could almost not believe how African scientists were be able to identify variants, be able to have responsiveness, be able to really move technology, science, information systems, innovation around the last mile forward. So I think also the world population and the world scientific communities were pleasantly surprised by the African scientific capabilities. And I think it will stood us in great benefit as we move forward and preparing to get out of this pandemic, to protect our people, and to be not have these massive inequalities in the next years to come.
Thank you. I feel like you've covered everything that we're going to be talking about. So let's just dig straight into some details around this. So the wide range of public health measures, as you've rightly said, all of you, vaccines have been lauded, for helping to bring some sense of new norm and protecting lives and saving economies. But globally, the statistics say that 64% of the world population has received a vaccine, not just a vaccine. And this amounts to approximately just over 11 billion doses. But we only have 14.4% of people in low-income countries. We cannot, only about 14.4% have received a dose. So availability of the vaccine remains very critical to the management of this pandemic. And, someone said earlier on last year that none of us is safe until all of us are safe. But then to achieve this, we need to make these vaccines available to all who need them. So let's say something. Let's discuss or talk about the availability of these COVID-19 vaccines in Africa. And I would like to start with Dr. Ndembi from Africa CDC. Would you just shed some light on where we are with availability and what these issues have been as far as availability is concerned?
No, I think that we have come a long way. I think my panelist friends here can confirm with me. It's really we've come a long way. We went to the acquisition of vaccines with resources. That's unusual. With $2 billion US, but the $2 billion could not be translated into vaccines during the acute phase of the pandemic. So what does that mean? It means that even with money, I think Morena mentioned that there were issues of really getting access to the vaccines for the continent. So now we have enough vaccines. I'm not sure we have enough to vaccinate 70%, but at least we have enough vaccines currently. But those vaccines should translate into people actually getting jabbed. Getting the vaccines from port to arm. The vaccines will leave the facilities or fridge freezers to get into people's arms. Mm-hmm. So this is unique because our head of state are putting a lot of resources, a lot of political commitment, and really is historical from the continental perspective, seeing 55 AU member states and head of state leadership of this continent putting COVID-19 as the top of their priorities. Very important. I can see for the past at least 18 months, they have met more than they have never met as head of state of the continent. So there's still this disparity. You've mentioned it, 15% only fully vaccinated on the continent, if you compare to the rest of the globe. But we'll tackle some of these as actually the discussion will unfold. One, the key role of hesitancy. Second, the logistics. I think when I say we, all AU member states have underestimated the deployment of COVID-19 vaccines. Very important. And then the third element is really around ensuring that we have a robust risk communication and community engagement strategy. And lastly, probably, which we'll touch base on, how do we ensure that as part of our own responsibility, we in the future should be able to respond immediately rather than probably relying to the rest of the globe. I think I'll pause over to you.
Mm-hmm. Thank you, Dr. Ndembi. And just Dr. Morena, any reflections on the issues of availability?
Yeah, so so I think we know that we are a continent that was the last to get vaccines, which is sad, particularly, as I said earlier, in terms of everybody was looking after themselves. And I think, and I don't know, I don't know much about behavioral sciences, but I think what it has taught us is exactly that we need to probably put a lot more attention to, whilst we focus on the science, but I think there should be another arm that looks at why are people hesitant. I don't believe that we have a lot of anti-vaxxers on the continent. I think people are vaccine hesitant. And to what extent has this delay in receiving vaccines contributed to the hesitancy? So, in 2020, when there was an outbreak, I think people were very fearful, that, oh my word, what's going to happen? We don't know this virus. We don't even know whether it's going to be on a surface. It's going to be on our phones. Everybody was quite fearful. And if we probably got vaccines at a similar time that the Western world would have, I suspect that, we probably could have gone a little bit further. However, what happened is that with the passage of time, people said, oh, well, maybe I can survive. Is this really for us? And I think that delay, and again, as I said, I don't mean to claim, what goes through people's minds, but I think that's a portion that really should now be well understood. Also, including the fact that around vaccines in general on the continent is not something that is a norm. When we think about vaccines, we think about pediatric vaccines, we think about EPI vaccines. Whereas in the Western world, we know that the likes of flu vaccine, if I can make that example, is given widely. And whereas on the continent, if I make an example of flu, is not given widely. So adults are typically not ones to go for vaccines. So now, coupled with the fact that there's a delay, and is this the right vaccine for us, and all of that has probably contributed. I don't think those are the only issues, but probably contributed to the vaccine hesitancy. I think we're lucky that we have a fairly young population on the continent that has stood us, in good stead. But that as well, Lucy, I think I do fear that, the complacency that obviously comes with that is that should we get, a much more virulent variant, compared to even the other ones, even worse than Delta, this hesitancy will certainly, I think Africa will be worse off, on top of the fact that, we have low coverage rates. So, yeah. But that's the state of affairs now, and obviously a lot more work needs to be done because, as Nikkei says, now we have enough supply. So the question is now, what do we do with those supplies? We are learning of expiring vaccines and all of that, which is a great concern. So yeah, a lot more work needs to be done. Thank you.
Mm-hmm. Thank you, Dr. Morena. And I like the link that you make between the delayed availability of the vaccines and the eventual hesitancy that we are seeing on the ground. And we'll come back to reflect on what that means then and what we can do around that to tackle that as a continent. But Professor Petro, do you have something to add on this issue of availability on the continent? And then we'll just move on to a discussion on inequity. Mm-hmm.
So we know the history, and we know even today, Nikhaze made the comment. There's generally viewed that there is sufficient supply for the globe to vaccinate, get to the requirement 70%, minimum 70% vaccination, particularly in low and middle income countries, which are way below. However, we must not be complacent. If there is another variant of concern, and if that variant in concern is, like Morena is saying, is a Delta or worse than Delta, if you look at the projections, which says that the world will probably need 2 billion doses of vaccines per annum, those are the lower scale projections. Others says 18 billion doses to cover full population. Supply will be under pressure again. If there is a new variant, we will be prioritized last again. Africa will be slipped back into where we were a year ago. So it is of immense importance that we become self-sustainable and we address issues of availability of vaccines. And I think we can certainly today in the seminar look at where we've been and where we are now. If we compare 2020, what was the vaccine capacity on the continent? Where is it now? How many tech transfers did we have in this continent in the last 40 years for vaccine production? And where are we today? It is a huge difference. And I do believe that this continent must be vigilant and prepare ourselves to be self-sustainable and to be able to supply vaccines for our people even in the shorter term, because we don't know how COVID is going to develop and further develop. And on vaccine hesitancy, it's an important discussion that we should have, and an advocacy that people like us around the table need to also bring the message across how important it is that we still must continue vaccination.
Mm-hmm. Mm. Thank you very much, Professor Petro. And yes, supply side issues, like you say, if something else happens now, and as Dr. Ndembi said, we are still living in very uncertain times, and we don't know what the next couple of months will bring on board. But just related to this issue of availability, I want us to talk about inequity. And vaccine inequity within Africa, as well as between the continent and the rest of the world, remains a key barrier to availability of these vaccines. And which we all know, it's been said and we know already, that it will have a lasting and profound impact on socioeconomic recovery across many settings, but especially more so for low and lower middle income countries, and where the majority of African countries actually fall. Well, and if we think about this, some countries in the global north have received vaccine doses equivalent to more than 300% of their population, while some African countries have received less than 10%. What they need? They need more than this, but they only have 10%. How can this vaccine inequity, this issue of vaccine inequity within Africa be tackled? And I want to start, any of you can start, but from a continental perspective, I don't know, Dr. Ndembi, do you want to?
Yeah, let me start here, because I think that question of inequity, the more we're reflecting on, the more we really have to find solutions for our own problems. Because I won't blame a country to get 300 million for their own population. That'd be quite honest.
Yeah.
But for global solidarity, it's not good. But now the question is, what are we doing to address those problems? So 99%, I know Petro, Morena, they know these figures, so I'm just telling you for our audience. 99% of the vaccines currently being utilized on the continent are being imported. You know what it means? It's a lot of money, a lot of resources that we could sustain jobs on the continent, build a reliable vaccine manufacturing ecosystem. So I think the debate can be really reframed. What are we doing as part of this continent to build a resilient health system, including vaccine manufacturing? It's possible. We can do that. We have seen the momentum. We have seen what Prof. Petro and Morena are doing in South Africa. They just need to kind of enable the environment to be able to produce those, even what I'd say, or at least even 20% of the 40% that, only 60% that we need by 2040. But the point is, do we have those or an enabling environment for them to be able to do so? I think that's the question probably we need to reframe. So, inequity, I think we tackle it from the early phase of this discussion by saying, in the midst of a pandemic, it's quite obvious that countries, they have the primary interest is their own people, okay? So we need to learn from it. That's why we started your first question. We learn from it. We're learning that we need to be ready. If now it's COVID-19, next time we'll pathogen X. If pathogen X in the next 10, I don't predict it, or 20, it's there, are we ready to avoid this inequity so that we have our own vaccines, we can deploy them across the continent? I just want to reframe probably that I put that discussion so that we don't go into continue complaints about not finding solutions. That's my issue. And the second is, now from the African Union perspective, what we do, we ensure that the 55 AU member states, they have access to the vaccines. So in theory, within our system, there's no inequity. We secured $2 billion to actually procure or acquire the vaccines for the 55 AU member states, and ensuring that they have a proportion to their population based on the World Bank population size estimate. Now they have to go and claim those vaccines for them or for their own populations, what I mean. But again, out of those 55, only 45 were able to claim. So that's to bridge that inequity and ensure that the 1.3 billion people that we serve, they have access to the vaccines, despite those challenges. Working together with the whole of African approach, that's our own strategy. I'll pause here and allow also my colleagues to comment. Over.
Maybe I can come in there. Nika, is absolutely. Africa is not one country, but we're actually one country. We're talking about Africa incorporated. As a continent, we need to coordinate and build together. I just maybe want to add something in terms of how do we ensure that we beat the next pandemic. And very clearly, the Partners for African Vaccine Manufacturing under the AU banner and Africa CDC has put such strategies in place. And the first one is we need to have an early and an accurate warning system. That is a science system which is epidemiology, surveillance, communication. The second one is that we need to ensure that we invent and we establish platforms and facilities that can fast respond to product production. And this is not only vaccines. We know that for a new pathogen, it might take a few months to get a vaccine, but early on, be sure we have masks, be sure that we have other protections and available as therapeutics, not only vaccines and oxygen. Very important that we have partnerships. And I think for pandemic preparedness, it's public, it's private, it's academic, it is civil society, it is governments. Those partnerships must absolutely be in place. And we need to have various platforms to respond. You know, we very much embedded Afrigen in the mRNA platform for good strategic reasons, but the PAVM strategy makes provision for other platforms that will also be rapid moving and suitable for other pandemics. And then the last one is we cannot be complacent. We must be very, very careful not to become complacent and to blame, but to really be on high alert at all times.
Mm-hmm. Mm-hmm.
And I mean, Lucy, I think actually maybe even later on, Petro should actually expand on what the hub, the mRNA hub is, because perhaps your audience, maybe some of them have heard, some of them have half heard, some of them have a quarter heard, but I think it's important because for her maybe to outline what the hub is intended to do. But let me just firstly talk about the pain and that's how the hub also was created, because there was a pain, there was a gap. But even from our company's perspective, I mean, I can't forget the period between June and December of 2020, when we knew that vaccines were being developed. There were partnerships that we knew of, in terms of just our historic business. However, we couldn't get any headway in terms of getting any tech transfers through. And we thought, oh my word, we're established to respond. And we have links, we pick up a phone, but we couldn't make any headway, even amongst the many vaccines, over 20 vaccines, you call the East, you call the West, we just couldn't get anywhere. A lot of people were saying, BioVac, just wait, we're still busy, we'll come back to it. So it was a real pain that we felt in terms of not being able to respond. We felt that our arms were cut off, which essentially, what I'm saying is that because, there's a reliance model, and I think we should have some reliance model at some point, but it really then drove, particularly the WHO in establishing the likes of the mRNA hub that I think Petro should go through. But I also want to make parallels, Lucy, with what's happening now in Europe. We've been reading about Ukraine and Russia and just generally, the tragedy that's happening there. And when I talk about, I draw parallels with what's happening with the pandemic, with what's happening in Europe. What you're seeing now is that there was a lot of reliance, gas supplies, energy supplies from Russia and all of that. And what you're reading now, particularly in terms of what's happening with Europe, Europe firstly is re-looking at its strategy. A lot of the countries are saying, oh my word, I wanted nuclear plants to now end, and I think I must extend them. I must re-look at my dependence on others when it comes to energy. Now, this is what's happening to Europe, and people maybe can follow and understand why countries are now going to be, be looking after themselves, okay, using this example. Now, if we can understand this example, and that's what's happening in Europe, this is what we're talking about when it comes to vaccines. So what we would like the globe to understand is, and that's why I'm making parallels with other crises, because we're talking about vaccine hesitancy, vaccines getting to be late, and others are questioning, Africa, why do you still need to do it? There's an oversupply. What are you guys going to be doing? Don't you think there'll be many suppliers? All sorts of distractive questions, that we are getting about why do we need to have vaccine capacity. And I'm saying, let's look at what's happening now, in terms of the energy crisis in Europe. Why are all the countries, as much as European countries are very tiny in nature, why are they now thinking, oh my word, I must rethink, I must extend my nuclear plant, maybe I must build more plant, I must do all of this. So it's exactly the same thing in terms of what's happening in the crisis. And Africa must also, and that's what Africa has decided to do, to say, we'll work with the globe, but we must, reestablish, where there isn't, we must expand. And then we have the likes of WHO that is facilitating this whole thing in a very, very equitable manner, where it's a sharing process.
Yeah.
Thanks.
Yeah. Thank you. No, thank you very much, Dr. Morena. And actually, I would like us to jump into the discussion on manufacturing vaccines within the African continent, which is where I think Professor Petra and yourself will have a lot to tell us. So maybe Professor Petra, as Dr. Morena has indicated earlier, maybe just tell our audience a bit about what you're doing.
Thank you. Let me give context, broader context. In 2020, under the COVAX initiative, when the first vaccines were approved for market authorization, and it became very clear after 2 months that no of these vaccines are going to find their way into Africa. WHO under COVAX, the CEPI, Medicines Patent Pool, took a very, very important task on. And a decision was made to fast track manufacturing capabilities on the African continent and in low and middle income countries to produce COVID-19 vaccines using an mRNA platform. Good reasons for mRNA platforms. The two vaccines that first approved were mRNA based. It is a very flexible platform, it's safe. There's very great benefits for these platforms, and they're future relevant for future vaccine development. And the decision was that the model that will be implemented to do that is to create a hub, a technology transfer and training hub, somewhere in Africa, and that entity will be fast-tracked to produce a vaccine, a COVID-19 vaccine, through a tech transfer received from either Moderna or BioNTech or CureVac or one of the key players that already has market authorization or moving towards market authorization, and that we will fast track the establishment of clinical trials, supplies. We will transfer to BioVac within a period of a year. BioVac will have capacity to produce 100 million vials. That's another 500 million doses for the continent. We will follow up with 5 or 6 other sites on the African continent as a first priority to boost capacity for manufacturing. The model, even today, is a model of technology, vaccine design, development, production, and transfer of technology will go to 23 other countries in low and middle income countries to build significant capacity for low and middle income countries to produce their own vaccines. And in Africa, there will be 5 technology transfers. What did not happen is the tech transfer didn't happen. And I think Morena alluded to it, Nikais alluded to that. So the mRNA hub with fantastic support sit back and actually started with partners and develop our own homegrown COVID-19 vaccine. It will take much longer, but it is done in creation of a platform which will allow us also to do other disease targets and other immunogenicity targets, other diseases of importance to low and middle income countries can be taken through this platform and vaccines developed. So this is a full alignment with the Africa Union strategy to build capacity, but it's also focusing on low and middle income countries to ensure that we build capacity and capabilities utilizing mRNA, not only for COVID, but for future. So this is a model that we're learning, we're building, and that it is of great importance that we do this successfully with our partners, BioVac and the African Union, to ensure that we have the sustainable capacity that is needed for future pandemics. Mm-hmm. I don't know whether Morena, do you want to add anything?
No, Nikais, I'm not sure if there's anything more to add on that.
Yeah, sure, Morena. I think I think you. I'm sure, Lucy, you have the best mind of the continent to speak on vaccine manufacturing. I just want to be sure that you selected carefully your speakers. I think what Petra and Morena have done for this continent, they deserve an award. We need to find the best way to channel that to them. But the point here is we need people like clones of Morena and Petro over and over for this continent to get out of the wood. This inequity, we cannot keep on complaining. That's my issue. If we don't have solutions, we keep on complaining, inequity. Tomorrow there's going to be another crisis. For those that have been in virology, you can study basically every 10 years, a new virus will emerge. And it's quite clear why, because we keep on tampering into animals' ecological systems. It means they're going to jump into humans. If they get into humans, we need to be prepared. That's the reality. So as part of the continent, in April, the 2 year or so, my panelists attended the summit on vaccine manufacturing, with emphasis on security, health security for this continent. Subsequently, we established the partnerships for Africa vaccine manufacturing, with really a key goal, a target, 60-40, manufacturing 60% of vaccine by 2040. But you cannot do that if you don't provide enabling environments. Financing, provide infrastructure, regulatory. Morena and Petro can talk about tech transfer and IP, how cumbersome is to get those ones. You need to put in strong regulatory system, market shaping, market demand, and then demand intelligence, and also all components related to accessibility of the vaccines. So critical. Then we were endorsed by the head of state to drive this component around vaccine manufacturing, because they found this is very interesting, and that we need to really take the lead as a continent if you really want to have our own health security at our hand. So that's very important. Then subsequently, we started looking at how do we do with vaccines that are currently being produced on the continent in terms of market shaping, demand intelligence, and so on. How do we cope with countries that have not achieved maturity level 3 to keep the standard? Because that's going to be an issue subsequently. Vaccine made in Africa, that's that. So we're trying to be sure that we keep those standards the way my colleagues at BioVac and also Afrigent are doing. And we have now a continental framework for action, which will guide our strategy in terms of vaccine manufacturing. That's just what Petro beautifully put forward. Over to you.
Thank you, Dr. Ndembi. Actually, because I also wanted to ask you about the policy and continental strategy to bring this all together, this manufacturing within the continent, the strategy. And I think you alluded to some of those issues. And I don't know if Dr. Morena wants to jump in and.
Yeah, I think one of the so I think what Nikes has described is, when we think about vaccine manufacturing, sometimes people think about bricks and mortar and a vial, and people behind it, So yes, there needs to be shiny equipment. There needs to be a vial that goes through, and people think in a very narrow sense in terms of how it is, which simplistically you can. But I think what Nikes is describing is that for that vial to ultimately come, a quality vial to come out, you need an ecosystem that would ultimately ensure that that vial comes out. That vial just doesn't come out on its own. So that ecosystem is important. So you need to have the right regulatory, because we are in a regulated, and we need to be in a regulated space, and we need to have high quality because we're dealing with human beings. But we need to have those skills, and how do those skills then come through? Where do we tap into those skills? Basic things like energy security. These are plants that are big, a lot of investment. So we do need to, understand that whilst we're talking about just this vial, that contains vaccine that's going to be protecting of somebody, but that, the engine that's behind it is actually much bigger. So I think that's my first point that I'd like to make. The second point is around this topic is for people to understand, and I'm hoping that our audience is converted, but I think it's an important point that we need to continuously re-emphasize. That the case earlier also made the whole thing about the PAVM strategy looking towards 2040, 2060 onwards. Now that's not because those numbers are there just because we want something to do for the next 20 or 40 years. This industry is hard. It's hard and it's long, and you need to have patience. And I'm not only talking from an African sense. If you just look at the vaccine world out there, even prior to COVID, who is investing in vaccines? It's not as many as pharma. Now, why is that? Is it because it's just it's a tough industry? You're dealing with biologicals, so it's not easy. It's not for the faint-hearted. The rewards are great in terms of being able to save lives, But so what I'm saying is that we need to have a long-term vision. One of the things that I think COVID has done on the positive side is that because of the nature of the virus, SARS-CoV-2 is a fairly stable, let's call it a fairly stable virus, and let's say we compared with HIV as an example. Now that has enabled vaccines to come at such a, call it a fairly rapid stage. But that does not mean that that's what's going to happen in the next pandemic. We don't know which virus is going to be there. We don't know which bug is going to be there. What if it takes 3 or 4 years for a vaccine to get developed? Now, for us to be able to plan for that eventuality, for an even worse pandemic, we need to make sure that the systems and the manufacturing capacity is there, and we need to build on it today for that eventuality, and not think that, vaccines were developed less than a year after, the pandemic was declared. Oh, therefore, next time we will need to do that. That's, viruses work in a very different way. The case is more of a virologist than I am, but I'm just saying that we should also just be aware that we have a lot more work to do. It's a long term, and hence, what we're talking about in terms of what the hub is trying to do and everything is so, so important, and we shouldn't forget this in the next coming years or months even.
Very good reflections there. I almost get some goosebumps listening to you, Dr. Morena, but hopefully it's not coming soon. We will have some bit of time to prepare. And I want to come back to you, Professor Petro, on the role of public-private academic partnerships in the vaccine manufacturing and supply chain. What do you think? What's the role of PPEs in this space? PPE, not PPE of yeah. Mm-hmm.
I believe that partnerships, unconventional partnerships, are absolutely essential for us to establish and reach the goal that we've set, the 60-40 goal for the continent. And maybe if I can just take a step back, Nikai's very early in his opening statement made the comment about 99% of the vaccines used on this continent are imported. That is a huge economic sector. Part of what we're doing here is not only to have health security, it is essential, but actually to build a whole sector, a socio-economically viable sector on the continent, and for young people to provide jobs, our young population on this continent. So very important if we look at what are partnerships. We have seen in the last 8 months how the public, the private sector, and the academic sector and civil society all pulling together to a common goal. How do we ensure that we minimize the impact on this continent? How do we ensure that we start building and preparing the platforms and the foundations to never, ever again have to be in this kind of situation? So the beautiful thing about public sector can leverage resources, and public sector are very important in advocacy and policy setting. Without proper policies, we will not be able to implement the strategies as is required. And these policies are also around procurement, preferential procurement for localization, are one of the key policies, regulatory policies. The second one is private sector are really good at delivering, to be cost efficient, to be market orientated, and to drive products to the markets. Get products the last mile and get them to the people, because without that drive and agility and cost effectiveness, we also don't have a complete system. The academic institutions, most of the basic fundamental work and even up to designs of vaccines can eloquently happen in academic institutions. That is where development can be de-risked. And the knowledge base in academic institutions will be public and the private sector. Evidence-based policies comes from research programs. Surveillance programs can sit very suitably in academic institutions. civil society, the understanding of civil society on how this total landscape, this eco-landscape will be supported is incredibly important. So we have seen with the mRNA hub, if anybody would ask me, we're now 8 months since the announcement of this hub, what are one of the most profound enablers? It was not technology. It was not, it is technology, and it is the scientists, and it is a can-do team, and it is the support that we receive globally. But the value sits in those partnerships that are true partnerships, and those partnerships which are from different places. South Africa, and I think the continent is now is looking at establishing an institute or institutes for pandemic preparedness. It's an essential intervention that is starting to happen. I cannot see those institutions or structures operate if they're not public, private, and academic partnerships. So I think essential for what we need to achieve are those partnerships.
Mm-hmm. Thank you. I don't know if Dr. Nikes or Dr. Morena have something to add on the role of partnerships.
No, for sure. I think partnership is one of the components on the new public health order. So working closely with the private sector and ensuring that we really redesign this global public health architecture. Very important. If we always, that's probably at some point very neglected, not coming prominently in some of the discussion, but we're trying to push to ensure that there's a really synergy in what the private sector is doing in line with the continental aspiration. Let me just touch a little bit based on that. We have 8 bold programs as part of the implementation of the framework for action. One of those around the setting up vaccine manufacturing deal unit, which is important. It's quite important that we take that risk. I think Peter did mention, and Morena as well. Someone has to take the risk, either the private sector or the government, meaning putting in resources to ensure that we have a viable, sustainable vaccine manufacturing ecosystem. We need $30 billion to be able to achieve the continental strategy. That cannot be alone mobilized through the government. We need the private sector. It's very important. So far, 1.3 billion have been pumped into for vaccine manufacturing on the continent. 15 African AU member states have really committed to embark into the vaccine manufacturing industry. None of this can be achieved by the government only. The private sector, they're going to play a fundamental role in here. I think our vision from the Africa CDC, African Union, we're looking at it really as a joint venture between the government and the private sector. If you really want to sustain the entire vaccine manufacturing ecosystem. We have seen 2 or 3 countries, I'm not going to name them, they shut down completely vaccine manufacturing because it was 100% owned by the government. And that's why the partnership, that P, Partnership for Africa Vaccine Manufacturing, we're bringing all stakeholders on board, playing the convening role from the Africa CDC, African Union, to ensure that we move forward and be prepared for the next pandemic. Over to you.
I think, I'd just like to finish off on this section, Lucy, by just echoing what both Petra and Nikes said about the ecosystem. So, in my dream, and I think Africa is probably will realize this dream unfortunately through this tragedy, is that, we see the likes of Silicon Valley that everybody knows about. We see, the Boston area in the US, that we look at and we salivate, we see the likes of Singapore and all of that. Now we often, look at those hubs with the eyes of money, instead of us looking at it in the eyes of an ecosystem, because it's really that enabler. And once we get that engine going, then it's just going to be a flywheel. So it's really the intimacy between government, private sector, and multilateral organizations working in synergy. That is really what's going to make us all sustainable. As in cases, private sector is very willing to take the risk, and money is not the problem. We can access money, but money needs to know, okay, how sustainable and what risk is there? And then we need the other elements to kick in so that private sector can then take the required risk, which it should. you know. But we need governments to come through, give us policy certainty, you know, and a little bit of visibility. We need universities to make sure that they're training. And again, we should be swapping, you know, we should be swapping skills between universities, and they should be coming this way and that way. You know, one of the fears in our company, I don't have a fear in losing staff members to an African based entity, you know, even in South Africa. My fear is losing skills to overseas, where our people will say, I don't have opportunities in South Africa, I'm going to London, I'm going to the US, and I'm going. Why? Because the ecosystem is not is not solid. And that's what we need to be looking at, so that a graduate can then come and work at Afrigen. Once they're tired of Afrigen, they can come to BioVac. And then we're just creating that right ecosystem so that you don't have to lose the skills, you know, to Europe and the US. I think that's probably the biggest threat if we do not contain this. But I'm hopeful that hopefully the turn is tied.
Thank you. In fact, there was a big discussion on brain drain from Africa. In an earlier discussion, and I'm glad to hear you bringing it up now, Dr. Morena, and I like the way you put it. I want to throw in the population in these partnerships. So we have public-private education or academia. I'm throwing back the population, and in this one, the angle relates back to the discussion. I think all of you alluded to vaccine hesitancy, the skepticism around it, and this is a deep-rooted issue. Unfortunately, with historical and colonial legacies in the continent. And I'm just curious, how do we handle this? And what have we learned from other regular or routine immunization programs that we can transfer into COVID-19 vaccine? Because yes, we will have it, we'll manufacture, but then how do we get it to people's arms? And especially adults, you know, who can make this decision, who need to make this decision for themselves.
No, let me come. I think vaccine introduction has been something over and over that it's not quite easy when you have a new product to get into the whole society approach quite easily. We know that. More so in the midst of a pandemic like COVID-19. So I think we have there's a breakdown. I mean, there are social behavioral scientists. I'm not one of those, but they have studied at least they have a 3 threshold. There's a 20, then 40, 40. To get the 100% vaccinated, you'll never get 100% anyways. So the likelihood of getting 20% vaccinated is quite easy. You go into no major risk communication strategy, you get 20% vaccinated. When you get the 20, you're going to be in trouble to convince the 40, the second block of 40, to get vaccinated. That's where you have to deploy really extensive strategy, risk communication skills to get those 40. But by the way, the rest of the 40, it's going to be a fight, really, to get them to embrace that. Traditionally, what we have seen, and confirmed by WHO data as well, countries that are not doing well now on COVID-19 are not also doing well on their routine immunization program. So something is wrong. So we need to address some of these systemic issues before bringing COVID-19 into play. Very important. So we have looked at that archetypes on 8 infectious diseases. They are not doing well. They're always less than 50% coverage. Now, if you bring COVID, that's going to be an issue. So COVID is not a problem, but it's how we approach people into getting vaccinated that's the problem. Morocco has always been doing good on all routine immunization program. The question is why and how are they doing that? We need to learn from those ones that are doing well to be able to resolve some of this or unlock some of these issues. The second point, which I think from the scientific perspective, is quite unacceptable that some of these vaccines, 0 clinical trials are being undertaken on the continent. We're a continent of 1.3 billion people. We need to engage the community with the community. You're going to get product somewhere, no clinical trial on the continent, and how do you want the community to embrace those products? I think, let's be quite frank with us. There's a breach, there's a really complete disconnect between the community and the science. And we bring the community when we have the product. They have to be part of the product, co-create with the scientists.
this is a product, this is what we intend to do. We need people, you consent, you get into, you enroll, the final product, this is it. You take it or you, I would defend the product because I was part of the trial. But that's not the case. We need to reverse engineer it. I don't think it's unacceptable for us to be actually at the end of the queue when all have been decided, and now we need somewhere to get the 99% that we said earlier. I think we need to change this. If we don't change it, that's part of what I've said, reshaping the global architecture. We need to be part of the discussion. We need to be around the table to discuss all this and then be sure that we're all involved. I mean, that's a very important point that I think that will shape or change vaccine hesitancy across the continent. Very important. I'll leave you with one single example. I take it, I quote it every time. It's the Systemke clinical trial. I think Morena and Petro are here. How many South Africans enrolled? I think there are thousands South Africans involved into that trial. And then they are more inclined to be defending the product, because if you say there are 1,000 deaths, they'll say, no, we have not seen it within our community. We're part of it. So I'm just saying that because we don't speak much about it. We can do it. We have seen South Africa with Omicron. That's from Africa. We informed the rest of the world. We can do it. We have more than 200 clinical trials across the continent that can do phase 1, phase 2, phase 3, and even real-time or real-time vaccine effectiveness study. I just want to pause there and give a chance to my colleague as well. Over.
Maybe I can come in here. I think, Nikesh, you are absolutely spot on. There's the issue of, we are scientists, and I'm taking that responsibility. We must be very careful how we communicate and what we tell. And Lucy, your point, if we don't take the community with us in this development, we will deal with issues of last mile not happening. I think the last survey that the Africa CDC did on vaccine hesitancy on the continent was 1 in 3 people. That's 30%, 33% of the population will not go for a vaccine, will not be vaccinated. That is, and I think that may be an underestimate, because if we see in South Africa now how the vaccination rates are very slowly increasing, there's issues of vaccine hesitancy. So I do believe that clinical trials is a very, very important means to involve the communities and to also address issues around fear of vaccination. The second one is we need our influential people to change the narrative and start addressing the issues of vaccine hesitancy and the importance of vaccination. There's an education process, but there's also an information sharing process that we need to do. I also believe that we need to be careful how we communicate. We had numerous examples of how social media really caused problems in how ignorant people communicate about a fact that is not correct. We need to listen to the people, we need to engage with the people, and we need to work through their fears. And there's another component where I think we can contribute, and that is technology. The fear of needles, some of the work that Greg Hussey and the team did in South Africa, where they actually unpacked what are the reasons why people won't take a vaccine. It's amazing there's a high percentage of people that's actually scared of a needle. And there's a technological base where we could, in fact, address some of those fears through technology. I've recently been exposed to a product which is called PharmaJet, which is a needleless applicator for vaccines. And it's accurate, it is safe. Those are some of the things that we need to bring into our armor to ensure that we reach those levels of 70%. And in some disease cases, for childhood vaccinations, it should be 100%.
Mm-hmm. Wow. Thank you. Very, very insightful. And I know we're running out of time, and I would just like to pass on some of the questions that we are receiving from the attendees to you. And one of this relates to Big Pharma. So how can we ensure Big Pharma companies, for example, Moderna, continue to uphold their commitment to publicly available sequences? This is from Abukar Mohammed. Anyone can take this one.
That's for Petro. Yeah.
Exactly. I was going to say the same thing.
I like how the button is being passed. So, yeah.
I think it's an important question, and I think part of the enablement of the sector in low and middle income countries is for Big Pharma that holds the knowledge and the abilities to facilitate, to honor their commitments. I have no doubt that Moderna will honor it. They have come out in various forums now to facilitate waivers within the during the COVID-19 vaccine. They've even made a commitment to invest in Africa, and Nikes can talk quite eloquently about that. So we will keep them to their promise, because that promise is essential for what we need to create in low and middle income countries.
No, absolutely, Petro. I think no, Moderna. Moderna.
Okay. So, I mean, so one of the things, and I don't have an answer to this, Lucy, in terms of going forward. I mean, we're just seeing the problem. So I think companies are coming to the party now. Are they coming to the party reluctantly? Are they being, I mean, we don't know what's happening behind the scenes. The question is, how do we make sure that they come voluntarily, or when we knock on the door, that the door opens up, widely and welcoming? I certainly don't have an answer, except the fact that they need to have some incentive. Now, what is that incentive, besides the fact that they can have a market and make billions of dollars? We need to find some mechanism, and I think part of the mechanism is to have an open discussion about, what is driving the reluctance? Is it, and quite frankly, I don't have the answer to that, but yeah, Nikes?
Yeah, no, very complex one, because we have at least cases at hand. But Morena, I take your point positively, in the sense that it's unusual. We have seen the movement, at least from the pharma across the continent. We see Moderna recently, BioNTech. I think it's a good move. We cannot get it all at the time, but it's unusual, at least, that we see that move. I think that push will continue. There's pressure. I think we want to be sure. I mean, Morena, correct this, and Pietro, correct these numbers. 20% of the global vaccine market is in Africa. We have a say.
25%.
25%. I'm very humble. I mean, modest here. 25%. So we have a say here to say, well, we like your product, but please, we need to go beyond that. Talent development, we need that. IP tech transfer, we need those ones. I think we're already seeing our head of state. They are vocal. They are speaking it openly. I think more and more will come, because now they really have perceived the risk of not getting through really all those details that we have been saying for years and years. I think my expectations, let's be optimistic here that things will happen. Might be slow, but pressure probably, we're going to crack through that, and that's going to be a breakthrough for the continent. That's our expectations anyway, in the long run. Over.
Thank you, Nikes. And actually, you begin to address one of the questions here, and I'll just read it. How should African countries position themselves when it comes to vaccine IP? Should they continue to fight for IP laws to be waived for catastrophes such as COVID, or work to build infrastructure to build their own? And I think our speakers have addressed this in many ways. Yeah. So related to that, I just want, there's a long question here, but I think which is very interesting. This is from Paul. What is your opinion on the number that we have on the situation in Africa? For instance, who assures us that the numbers are correct in what it takes to vaccinate people, or people infected in areas that lack on health infrastructure? Should we make some kind of prediction of real numbers based on the existent numbers? And Paul goes on to ask, and would this be an opportunity for the development of the health sector in Africa, including research leading to vaccines developed and produced in Africa, and also to better centralized health politics for all of the continent, then learning how to fish instead of having the fish, also apply to the vaccines? Better than having the vaccines would be, better that having the vaccines would be to have the capacity to produce and deliver them. And I think you've answered them in many ways, but I think he raises an issue here, a question here on data, on a reliability of the infrastructure around the data collection system. I don't know if anyone wants to address that.
Let me pick it from the Africa CDC perspective. No, yeah. I think it's time, and again, that's why we're here. I think the two speakers, Morena, Pietro, and myself, we need to start relying on our own findings, data. If you don't trust your own data, it's dangerous. I'm saying that very well. Because there have been at least comment out there. I mean, in the West, they're still looking at us. How did we survive all these 18, 20 months? I think the narrative out there was that all across the street, all of you see dead bodies, and it's not happening. We have to be quite frank that we are more prepared, or we're more prepared than the rest of the world. Why? We just came out through the Ebola pandemic. We are dealing with cycles of outbreaks as we speak. There are about 5 outbreaks on the continent. We're dealing with them as we're dealing with COVID as well. So those data, please continue to trust what we're producing, because they actually speak for the continent. So just to give you, we get data from ministers of health. We also have our data officers at country level, at regional level, at community level, and we validate those findings on a daily basis. So when I hear those comments, I really feel bad for the thousands of African scientists and data clerks spread across the continent to provide data to sustain this. But I'll end there saying, the rest of the world wouldn't have even trusted that it was Omicron coming from South Africa, but it was our data. So continue to trust us, and then we'll be sure that we provide solutions, because data will form the basis of all our conversation here. You cannot produce vaccines if you don't know how many people have been infected. You cannot prioritize your diseases if you don't know the burden. So please keep on trusting our data. That's the only way the continent can build a resilient health system. I'm just going to pose that on a positive note to say we just have to continue to trust our data.
Yeah.
And of course, the leadership of the continent. The leadership, now we used to only have WHO. Now you have WHO, you have Africa CDC, and then the head of state. There are several layers to be sure that we are successful in this. And then we'll continue to be successful anyways.
Thank you. And I agree with you. You know, we have a lot of learning from the Ebola legacy. And so, like you said, in many ways, Africa was prepared, or has been prepared, because we've had a series of, the Ebolas coming on, and we've done a lot around that. And again, also just reiterating your point, and I think it was Professor Petro who mentioned it. You know, it's I think the word is annoying that the world would not believe the capabilities of the African scientists, and yet now, as you say, we've done something. We reported Omicron in good time, and we are managing. You know, so yes, the data is there. This is for Paul. Yes, we have data. It's reliable data, and it's on the basis of this that a lot of other health system related issues or decisions are made. And one more question, I think this will be the final one. It says vaccines, testing, and COVID management protocols are okay. However, there is little talk and investments for nutritional security and healthy urban environments. This is very important in a continent characterized by food insecurity, with urban centers dotted with extensive slums, with inadequate access to wash. Is this not an omission worth looking at in COVID response and readiness for other potential pandemics? This is just a general one. Anyone can take it.
I think it's important. Yeah, and you can come in, Nikas. I think it's very important that we do not become one-track minded. We have to look at holistic healthcare solutions. We cannot forget about cancer. We cannot forget about TB. We cannot forget about the basic issue of nutrition and food security. We have to address all of those aspects in a concerted effort to have health security for the continent. And some are more difficult than others. We today talk about vaccines, which is a difficult sector, but we have to address all of these healthcare challenges. Very good point.
I mean, I agree. And when you look at the questions that are being posed, I mean, just to complement what Petra is saying, is that we're all looking at different parts of the value chain, okay? There's a research element that we're looking at, and then we're looking at social mobilization, let's assume, on the other spectrum, which means that we can't just say we need to start here. No, everything is essentially important, which is why governments actually have such a tough task. And even the likes of Africa CDC have such a tough task, because it's not that, manufacturing is higher than data collection or epidemiology. Everything is important. We need to understand that this is how we need to look at it. In parallel, yes, we need to have sector specialists, but everything is important to take us forward.
No, I agree. I cannot. I mean, I agree with the panelists. I think is what we've called the ecosystem. Everything is part of it, and all are contributing. No, let's just give up an example. COVID-19, you've seen the disruption in all sectors. So you cannot or remove or single COVID as part of health nutrition. No. We've seen how COVID has actually impacted not just the vaccination, on other vaccination program, immunization program. So there's really is a chicken and egg situation here where you don't really want to be sure, you want to be sure that all key sectors are being addressed without any highest priorities compared to the others. Over.
Thank you. No, thank you all. So thank you very much for this very informative discussions. It's been a great pleasure to have the opportunity for both me and I think all the attendees to listen to our panelists today, Dr. Ndembi, Dr. Morena, and Professor Petro. So thank you very much again for taking part. We are most grateful that you could find time in your busy schedule over the weekend to be with us today. And finally, many thanks to the LSE Africa team, Africa Summit organizers, and Firoz Lalji Institute for hosting. We appreciate the support from the LSE Events and Communications team for organizing and helping run the event. So from all of us at the LSE, stay safe, and we hope to see you at one of our events again soon, be it virtually or in person. Thank you. Thank you very much, everyone.
Thank you.
Thank you.